I'm going to introduce all speakers and let them coordinate amongst themselves. We're talking about managing the diabetic foot in Indigenous populations. We have Dr. Ahmed Casey, who's a vascular surgeon at Sunnybrook Health Sciences Centre and a wound care physician at Women's College Hospital. He obtained his medical degree from Queen's University in Kingston before relocating to Toronto to pursue training in general and vascular surgery. He subsequently completed a fellowship in limb preservation and wound care under the supervision of Dr. Richard Neville in Fairfax, Virginia. Dr. Casey is a graduate of the Harvard School of Public Health, where he obtained a Master of Public Health focusing on quantitative methods and is currently pursuing a Doctorate of Public Health in Health Policy and Management from the Johns Hopkins School of Public Health under the supervision of Dr. Ellen McKenzie. Included in that group is Jeremy Call, who's a registered nurse and certified diabetes educator who's coming from a home care background in a predominantly First Nations population. Jeremy holds the single nursing position for the Centre for Complex Diabetes Care at the Menoya Win Health Centre in Sioux Lookout, Ontario, providing resources, education, and expertise in wound healing for the outpatients and inpatients of SLMHC. Working in an interdisciplinary team, Jeremy's practice extends to the surrounding areas, including over 30 remote and fly-in-only communities, and he's aiming to improve access to expert clinicians working with the Department of Indigenous Services Canada to provide telewound services. Jeremy begins his journey with a Master of Clinical Science in Wound Healing program at Western University this fall. And as well, Dr. Yoko Schreiber, who received her medical degree at Dalhousie University in 2005. She completed a residency specialty and subspecialty training in internal medicine in 2009 and in infectious diseases in 2010 at the University of Ottawa. Also a Master of Science in Epidemiology and Community Medicine in 2014. It's 2018, what's happened since? She's been practicing as an infectious diseases consultant with a particular interest in Indigenous health at the Ottawa Hospital and Sioux Lookout Menoya Win Health Centre. She's an assistant professor with the Faculty of Medicine at the University of Ottawa, as well as the Northern Ontario School of Medicine, and is chair of the Indigenous Health Committee at the Association of Medical Microbiology and Infectious Disease Canada, and acts as a consultant to the First Nations and Inuit Health Branch and the Sioux Lookout First Nations Health Authority. Her interests lie in improving care for Indigenous people by providing direct clinical care in the Sioux Lookout region and collaborating on local and regional quality improvement initiatives and through research. We look forward to your presentations.
Thank you very much. I feel right at home with the snow outside. So as we begin, I first would like to start by acknowledging the traditional territories and the history that lies within of the peoples here in the London, Ontario region, which are namely the Atawandaron, the Haudenosaunee, and the Lenni Lenape, and the Anishinaabe peoples. And as we embark on telling stories from the north, which is Anishinaabe-Aski nations, I would ask that you be mindful of the individual level, societal, political, and policy levels factors that contribute to the social and health inequities that are faced by the Indigenous populations across Canada, and particularly in the north. How do I advance this? Okay. So there's no speaker disclosures that we could think of, so it's just the three of us. And our objectives will be essentially identify the key needs of the First Nations populations in the Sioux Lookout region, but I think some of these lessons learned will apply to a lot of First Nations populations across Canada. Appreciate the barriers that the populations face, as well as identify some strategies and come up with some ideas to overcome these barriers. So where is Sioux Lookout? So Sioux Lookout is essentially a small town of 5,000 people in northwestern Ontario, about an hour north of the Trans-Canada Highway from Dryden, between Thunder Bay and Kenora. It's about 2,000 kilometers from Ottawa. I don't know exactly from here, I didn't drive here. But the hospital is a federal provincial combined hospital located in Sioux Lookout, but the catchment area is essentially the size of France, live about 25,000 people, mostly First Nations, and encompassing about 30 First Nations communities or reserves, as many as we would know them, but we move away from that term. Understanding that healthcare delivered in the communities is under federal jurisdiction under Indigenous Services Canada, but again, receiving care in Suluk'at will be a combined provincial federal initiative. The healthcare is primarily based on primary healthcare services in a region. The hospital has 3 general surgeons. Up until a year ago, it was only 1 general surgeon doing the amputations and everything around them. I'm the only internal medicine specialist in that region. Everything else is primary care doctors. And the closest vascular surgeon is in Thunder Bay. Up until about a year ago, there's only 1 vascular surgeon in Thunder Bay covering all of northwestern Ontario. Now there's 3. When we have patients that require care, they need to be flown out of the community, either on a SCEDEVAC, it's about a few $1,000s, and needs prior approval from non-insured health benefits. In an emergency, they're flown out by a medevac, which is about $15,000, paid for by the province. And again, you can see the barriers in terms of getting prior approval to have patients come out for preventative care in Suluk'at, because we don't have necessarily all the resources in terms of diabetic foot management in the communities. Nursing stations are really just trying to make do with what they have and providing more like Band-Aid care. Some communities are better off, but most communities have challenges with that. So if you look at the burden of diabetes in the populations, and we've heard in the first speaker that the rates of diabetes are higher in Indigenous populations, and also the rates of foot amputations. There's numerous studies out there. We had looked in our specific catchment areas about the rates of major limb amputation in our catchment area. We've seen that in our region, the rate of significant lower limb amputation, we didn't even include toes, just toes, was 7 times higher than the average of the province. And if we even compare our catchment area to the Northwest Lynn, which was already in the nice, I think orange was the color in the first presentation, much higher than the rest of the province, it's 3 times higher. The Northwest Lynn has bigger cities like Kenora and Dryden in there, which have obviously road access, where then you can easily get to more advanced care. But the reasons these rates are so high is because access is limited. For example, when I see a patient, someone has an osteomyelitic or infected foot, wet gangrene, this care cannot be provided in the communities. They need to come to Suluk'at. If they're offloaded, get wound care, all this is in place, they still need to stay in Suluk'at for several weeks, up to 6 to 8 weeks at a time, away from their families. Often these are young patients with kids for extended periods of time because we can't provide those services in the communities. Our patients are also fairly young. In that study, the mean age was 50, which is about 15 years younger than in the rest of the Canadian populations who have amputations, and also predominantly men. But again, it just speaks to some of the difficulties in risk factor management that we face in the communities, access to preventive care, and so on. So I will have Jeremy come up and speak about his experience of providing patient care with patients with diabetic foot ulcers.
Thank you. Thank you, Dr. Schreiber, for that amazing, informative piece on the North. So I apologize in advance. I don't do public speaking, and I am quite nervous. Thank you for your laughter in advance. So I don't pretend to know everything about the Indigenous population or the North in general. I'm just here to tell some stories. The patients that have asked me, can you please tell my story? So this gentleman is Stanley. He's 40 years old, moderately controlled diabetes, very few comorbidities, but he lives in a community that suffers from a lot of barriers. So put yourself in Stanley's ill-fitting footwear. He presented to the nursing station with, by the way, he does have numbness in his feet. He does have a loss of protective sensation. He presented to the nursing station, which is this very small clinic, not a lot of staff. with this blister. He had pain in his foot, in a foot that doesn't normally have pain. He knew from previous amputations and injuries that this was not going to go very well unless he got care immediately. Stanley was dressed. His blister was not, unfortunately, taken care of in any way other than a simple dressing that was not provided using evidence-based care. Stanley was sent home, no antibiotics, no other interventions, no offloading. Unfortunately, Stanley suffered with this wound for 2 weeks, and he didn't really get much more than dressing changes. No swab was taken. He definitely was struggling with access to his care. So Stanley took it upon himself. He's fortunate that he's one of the few people in the community that are employed. He flew himself, and a flight from one of these communities is roughly about $500 one way. He flew himself and his partner to Sioux Lookout to present to the emergency department for the care that he knew he wasn't getting in the community. He came in to see me, and I immediately brought him down to Emerge, where he was confirmed to have osteomyelitis. Unfortunately, ultimately, he did lose that great toe. Very quickly, actually. A course of antibiotics kept him from losing more, but Stanley did have to come to Sioux Lookout for the care that he received. And a lot of my patients, they get labeled. This is a patient who, his A1C value might be around 10-ish. Not a great number for people that are in the South. Not a bad number from where I'm from, but we definitely see patients heal with A1C values of 14. So what does that tell you? That tells me that we can do more. We have more in our power that we can actually contribute to the patient care. Sorry, some of my presentation was already addressed, which was great. So I'm just going to move on to the next set of slides. These patients all have very similar stories of socioeconomic disparities, poor access to much-needed services, and tumultuous relationships with the system. For example, this gentleman on the left here, he comes from a community that has been on a boil water advisory for 15 years. And a case of water in his community is $55. A case of pop is $12. So these barriers, a patient like this presents to your hospital, unfortunately, he might get labeled as non-compliant. And is it non-compliance, or is it, is it really his choice to have access to the food that he has access to and the barriers that he faces? Unfortunately, no. I always tell my colleagues, I struggle, based on my description, you guys heard that I'm a little bit of a one-man show in the agency that I work for. Not their fault necessarily, but we're working on it. Sorry, I'll move on. So one of the issues that he had was supply chain, so footwear, access to products. It takes a month for prior approval for non-insured to access the advanced products that we use on our patients. So that entire month, we either eat the cost in our department, or patients don't end up with access, and they come back to me with regressions of their wounds. This gentleman here on the left specifically, he waited 6 months for custom footwear. When he got it, he started wearing it, and it actually caused a bunch more wounds. And he then had to go without his shoes. They were mailed to Thunder Bay, which is 4.5-hour drive away. And then ultimately, he had no access to offloading. In our hospital, I was just informed, actually not long before I came here, that the Northwest LHIN in our region has provided us with $5,000 to initiate a total contact casting clinic. Who's going to do that? Who's going to find it? Yes. Great, Dee's on board. I'm definitely going to need your help, Dee. So this patient in the middle, she's a single mom of 4 children, 40 years old. She lives locally, actually, walks everywhere. She lives in Darko all-purpose boots. Her eldest daughter has significant comorbidities and health issues herself, and mental health issues that make it difficult for her. Really, with those wounds, she probably should be admitted, have a multidisciplinary approach, take a look at her feet, really seriously take a look at whether or not we can help heal these wounds. But unfortunately, admission means leaving for children that have high needs at home. So I'm going to talk a little bit about the patient on the left there. She was an inpatient for a very long time. So talking about some of the barriers that our patients go through and doing things differently in the north. So that patient specifically, so history dictates relationships. A lot of my patients experience, they have had residential school experiences, or their parents have, contributing to a lot of the relationship issues that they experience when they present to nursing stations and to hospitals. Trust is a huge issue. I have patients whose mothers came to Sioux Lookout for, came to Sioux Lookout for some sort of intervention, left without a uterus because of the Sterilization Act. This is a history that Canada unfortunately has to face. So the systemic issue contributes to that. A lot of our patients deeply value their connections and their traditions. Many clients express to me that they wish to use traditional medicines in their wounds. So that's met with resistance for some obvious reasons. We practice Western medicine. We have licenses. These are the excuses that I hear. Dr. Schreiber actually had a great intervention for our patient that I was talking about on the left or on the right side of the slide. She wanted to use a traditional medicine in her wound. The nurses were fighting her, were refusing to allow her to do that. Dr. Schreiber said, "Who am I to tell her what to put in her wound? It's already contaminated. We're treating the infection. It can't really hurt." She wrote down in the chart, traditional medicine as per patient. And there was no more fighting. That patient was experiencing extreme anxiety. Her spiritual beliefs were not being adhered to. When it comes to traditions, every community is different. Sometimes we get patients who deeply value their traditions. Dr. Schreiber was going to talk about the use of herbs and poultices and birch barks and teas and things that they use to traditionally heal their body and their spirit, which do work. I had a really good example, and I lost it, unfortunately, of patient funerals, for example. So we have patients who they've been stuck in hospital for weeks getting treatment for osteomyelitis or some various wound, and there's a death in the family. The community level and the connections that I was talking about with these patients, it's actually detrimental to their health if the spirituality needs aren't met. So we now have a person who needs to attend a 2-day ceremony for a really important elder or loved one that they learned from and lived with their whole lives. So in Sioux Lookout, we would actually organize a lot of agencies and a lot of people to actually provide that. So a patient who's receiving inpatient care and isn't ready for discharge, we can actually achieve getting them to their home community, which is 700 kilometers away or more, and actually still provide the care that we need to and still ultimately achieve healing, but allowing them to meet their spiritual needs as well. So I'll just talk a little bit about the barriers to practice change, and then Dr. Casey is going to talk a little bit about the solutions. So when it comes to access to supplies and equipment, we're fortunate that we have an infectious disease specialist, but we talked about having lack of access to vascular specialties, orthopedic specialties, nurses that specialize in wound care, for example, or other designations that have expertise in wound care. I'm the closest thing our hospital has to a wound care nurse, and I'm a diabetes educator. I'm actually bound by my mandate to provide diabetes education and foot care, while the hospital actually utilizes me for wound care expertise in all areas of the hospital. I'm only one person servicing 30 communities and a population, or in a geographical area the size of France. I do have access to a few resources, so regional wound care team in Thunder Bay, for example, which is unfortunately underutilized. I have a colleague in one of the communities, one of the 30 communities. Her name's Heather Wright. She helps me a lot in advocacy. We talk to the Department of Indigenous Health and partners that allow us to address some of these things. So I'll let Dr. Casey talk about that. One of the resources that we're trying to improve upon is the Nurse Authorizer Program for NIHB access to supplies. We don't have access to basic tests in Sioux Lookout. We can do basic ABI, TBI, minor Doppler waveform, but we don't have the specialized equipment or specialists to actually provide comprehensive vascular or nerve studies of any kind. So, Dr. Casey, can you speak to the systemic underfunding as well as, et cetera? I'm sorry, the slide deck got a little bit mixed up here, but basically what I want you to understand is that our patients have traditions and values, and it's important to educate ourselves and understand them so that we can provide better care. And then at that point, I'm going to let Dr. Casey take over.
All right. How are we all doing? We're about 5 minutes over time. Is everyone okay? I've got 2 slides, I promise. So thank you very much for the opportunity to participate in this talk. It's a topic that's near to myself, and I imagine a lot of people here as well. So Jeremy and Yoko spoke to some of the challenges. There are many challenges, judging by the expressions in the audience as well. I think you all share the sentiment that there's a lot of work to be done, but I think we also have a lot of opportunities. I've had the privilege of traveling up to visit with the team a couple of times, and you know, I'm honestly humbled by the caliber of the people working up in the north. So yes, there are many challenges, but they are undoubtedly among the most dedicated and driven people I have ever encountered. 2 of whom are represented with us today. So that is their first advantage. And then there's also a lot of opportunities to make a difference. Not so much in people from Southern Ontario traveling up to tell our colleagues what to do or to treat the patients directly, but in supporting them with logistics and supporting them with education and other things. So partnerships are very important. There are many people, I suspect also in the room, who are doing work up north, either directly or indirectly. Wounds Canada is having an increasing presence as well. And you know, education really is the #1 thing that we can do to help out and be supportive. So Jeremy, myself, and Heather did a wound care workshop a couple of weeks ago, was it? It was very well attended. There were some very excellent discussions, and people are interested in creating algorithms and pathways for change. So the nice thing about this kind of work is that we're not really in need of any special technologies or expensive interventions. It's all about how you organize yourself better and bring in the services that are available to you. So that's something that we're working on, and we're trying to adopt some of the practices that exist elsewhere. This isn't new. People have worked on this in various jurisdictions. And I think the data collection and analysis is one of the most important things that we can do. We're working with some of our colleagues, Karim McIsaac's in the audience, I think, as well, to try and come up with ways of capturing data and analyzing it so that data scientists like Dr. Demestral, who's feverishly tweeting right now, can come up with better data for us to guide the conversation with policymakers and decision makers in our various jurisdictions. So to sum it all up, really there are challenges faced by all Canadians. I think this theme has been present throughout this talk, which are magnified in remote communities. So really it's what we're all having to deal with. These guys are dealing with it at a much higher rate due to some of the reasons that were expressed. So, you know, if you're going to try and do work up north, you got to expose yourself to the culture. You got to be respectful and mindful of the historical context. And you will have some excellent guides to help you through that journey. But collaboration is key, and, you know, Wounds Canada is a wonderful platform for this. We also have a Wounds Canada research research platform as well, headed by Dr. Stacy, who's also tweeting, I think, in the back right now. He's laughing at me. So, get involved, see how you can make a difference, and I think the future is bright. Thank you very much.